Well, greetings again. This is Dr. Bill Wyatt with the American Orthodontic Society, and I've been working with this case right here for, let's see, we started it 37 and going on 38 years ago, and I want to show it to you all the way. And we saw this lady just recently, and I got some pictures of her, and she works for Southwestern Airlines, and we did this over 37 years ago was when we started it, and we have eliminated the need for many of these double jaw surgeries. And now I have worked with the oral surgeons quite a bit with a lot of cases that we did surgery with, and they asked me one time to come with them, and they'd do the case, and I scrubbed in and watched it. And this is a tremendous surgery where you do both upper and lower jaws. I'm going to try to explain what happens in these cases, and let me show you this lady's picture here. And this is a young lady here. She's got a little periodontal problem, and apparently they've got that trait in the family, but she's taken care of her teeth very good, and she doesn't smoke. And if she had been a smoker, I think I would have not tried to do this case. But let me go over and show you and just explain the principles and everything in doing this. Now, this is a definite class 3 case. You can see a deficiency in this part right here, in the prominence in the lower chin, with the chin sticking out like that. Now, when she puts the teeth together, we don't have a gummy smile or anything like that. It's a good facial structure. The height of the face across here, and that'd be, if you had somebody really high, you might not be able to do them. Well, you could do them if they had to have it, but you can't reduce the height of the face as much. But if they were that way because of mouth breathing and other ways of functioning, and you got them swallowing right and pressing together, it probably over time would reduce the vertical height of the lower third of the face. Now here, when she closes the lips, you don't see much of this, and this is 2 of 87 when we started doing this case. And now I'm going to show the molar deal. And let me explain what we did. I scrubbed in with this case, another case now, and they take the whole maxilla loose. They cut it loose above the roots of the trees, and the maxilla is hanging here and held on by the tissue in the back of the mouth. And they take it and trim the sinus area out, and the one we did, we cut about 10 millimeters off of the sinus area to lower the vertical height of the face. And I was helping them do this, and I didn't get any pictures of it, but I'll tell you about it. And so we had the whole upper arch now was down here on and you could see it, and then the sinuses all up here. And they took a shears and cut 10 millimeters off of the wall of the sinus and pulled it up there and said, "Bill, how does this look to you?" And I turned to the old surgeon, I was with him, and I said, "Man, don't ask me that. I'm sitting here praying the moment's going to live." It was kind of a shock for me to see how this was done. So anyway, they trimmed this off, pulled it back up here and put it together, and I have to wire the bone to this. And then left it like that. That grew back. Then we went down on the lower arch, and the lower arch is kind of an oval-shaped bone like this, and we wanted to lengthen her lower jaw. It was way back from the back. This lady was a very poor-looking woman, you know, and we brought her jaw forward like that. Now what you do, you'd get back around the wisdom teeth, and they cut across the top. They went down on one side and then down on the other side, off from that. And now you crack the bottom part loose down here. And then you could slide the jaw out like such, and then you could screw the two pieces together. When you got these teeth out where you wanted them out here, you put that together. Now, you did that on both sides now, and you brought the jaw out. And then when you pulled it up out here, you didn't have any idea exactly where the condyle and the fossa were going to be meeting right here. Now, in this case, in many of these cases, you don't know how the condyle and the fossa is going to work after you get through with them. Now, where you do it without surgery, you bring the jaw gradually forward. And when you move the jaw out over a period of a few months, or maybe shorter than that, the condyle up here, where the condyle fits in the fossa, the neck to the condyle will lean back this way, and that'll let you bring the jaw further to the front. And then the gonal angle right back here in your jaw, you increase the gonal angle. In other words, you flatten it out. It'll be this way. And you flatten that gonal angle, and it'll let you carry the jaw further out too. And that's what we do orthodontically. We don't break or cut or do anything to the tissue. We just move it gradually out there. Now, I thought this over, the way to do this, and I've done about 8 or 10 cases like this over a period of time, and they hold up. And we had this case was done 37 years ago when we started it here, from there to now, and it's still holding good. Now, what we do on these non-surgical, in other words, we don't do the surgery. She had been to 2 oral surgeons, and they wanted to do this double jaw surgery for her, which should have been done that way if you're going to really succeed with it. But she didn't want to do that. I had done some cases like it even several years before. I had done a few of these cases, and I knew what I was doing here. And so I told her they could probably treat it successfully. The periodontal problem would be a little something we'd have to deal with. And she said, go ahead, if you lose the teeth, okay. But anyway, we started out. Now we took the 6-year molars out on each side of her mouth here. Now, we brought these teeth back to a class 1 relation. Now, if you put this in a class 1 relation, you're going to bring this tooth out to where it's fitting kind of like this in here. And so we brought this tooth forward till it was fitting in this class 1 relation, and we carried these teeth back here to a class 1 relation. And this was missing. And we brought this back, that would put this whole front back in a class 1 relationship here. And this is I'm just going over what you think about when you're doing a case like this. Now, by doing that, we hooked up here and went down to these teeth with elastics. And this is bringing these teeth back while it's bringing all the upper teeth forward. Now, if you need more of this bringing the upper forward, you bring this tooth back where you want it, and you put a screw in the bone over here and bond the tooth to that. You got this bicuspid bonded into there. And when you do that, that doesn't let this go back, but this can continue pulling this back here. Pulling it forward here, bringing it out. And that's the way we do it, the case. And that's the theory behind this. Now you're bringing the second and the third molar up to the class 1 position here that we've shown. I hope this doesn't confuse you. I'm going to try to erase some of that, and we'll do it over again here. These two teeth, we're going to pull them up, and we'll have them fitting in a class 1 relation. And that is the tooth would go up here, come up in this, and down. And now this bicuspid right here would come right in between this area here. And that's what we do in doing these class 3 corrections without doing any surgery. So we have pulled these teeth in a forward direction and these in a distal direction, pull these forward till it met, and that the energy to bring these forward, we pull these back, and bring this forward, pulls it back. If you needed to go back further, you'd have to put a pin down in the cortical bone and hold the teeth where they are. Now I'm going to run through this case pretty quick, and I'll show you what. Now the other side, we did the same thing on it. See, this is the 6-year molar. It's supposed to fit right in here, like that. And you bring it about out to where you bring this one out to this point, you see. So you move it forward at least that much, and we're going to try to bring these back that much more. Now, when you bring the upper jaw forward, you got to widen it out some because it won't latch over the lower jaw like you want it. If we go back to these, you see this was in a crossbite. Now this is the way this teeth move this way when you breathe through your mouth all the time. And it may be she may have inherited some of this class 3 problem, or it may have developed a couple of causes for that. So we had to expand the upper arch to do this. And so we put a big daddy wire here like this. And we brought this out, and then we had to come in and put some buccal root torque on these teeth to bring them out as we brought the permanent teeth up here out. We didn't want to just move the molars out. You had to move both upper and lower. So when you use this large wire, you can get all the lateral expansion you want. And if you put this torque in to teeth like that, the crown would move in and the roots would go up against the cortical bone. So we had to gradually expand this and bring the roots with the crowns as you brought them out like that. Now, she had a tooth turned sideways and in the lower anterior, and you told her to straighten that tooth out, you've got to have room here. And so we brought these teeth back and then got this tooth over, and we opened this space up plenty wide, and we started turning this lateral around. Now, a lateral tooth, if you look at one of them, it may be shaped like this, and then the root is pretty narrow down in here. And so, but if you look at it the other way, the root is wide, and then the crown comes up here, it turns the other way. In other words, the crown is kind of twisted from the way the root is, and the root's thinner here. So when you get this space open, you turn the crown around, but this flat area here will strip through a little bit, and I'll show you that as we do the case. All right, we took her 6-year molars out, and we started the case, and we were bringing that back, and we were getting the teeth to move forward. Now this is the cephalometric x-ray we took when we started the case. Now you watch, this is Pagonian right here. Now here this neck of this will straighten out, and that brings the jaw forward, and you increase this angle of this Pagonial angle right here, and that helps you bring it out further forward also. This is done over a period of time. We don't cut anything or anything like that, but you can watch it go. Now I'm going to show a picture of her later on, and I'll show that. Now, these are the 6-year molars, and they happen to be filled real bad, so we took the 6-year molars out to give us room to do this. We're going to pull these teeth right here forward up to something like that. And then this one will follow right behind it. And the wisdom tooth, this will drop in and fit on top of this. This will be hanging in the air. This tooth will fit over the wisdom tooth when you get through. Same way over here. These two teeth will move forward to about this point right in here, and then this bicuspid will go back to fit up in this part. And this gives you enough room to correct this. I'm going to have to go on if I finish this in a decent time. And I'm telling you that we could probably do 80 or 90% of the surgical orthodontic cases could be done with orthodontics alone rather than cutting on that many people. The price of a double jaw surgery in the hospitals nowadays would probably be at least $100,000. Back when we did this, it was $50,000 or $60,000. We went in on this one to be scrubbed in on at 7 o'clock in the morning, and we worked on her till 1 o'clock that day, doing the double jaw and a genoplasty on the lady. And that impressed me as the difficulty of this procedure right here, and that we were doing a lot of this on people. And now you can do this, and you could do it after I did this 30-some years ago, and I preached on it and showed it, but hardly anybody, I don't know of anybody that did it that I really know about. And so, but it is that way today, and this is the way surgical orthodontics can be done in the future. We do not need to do near as much of it surgically. You could do probably 80 or 90% of the cases. You could treat them orthodontically. It's kind of like we're going to show you out here. All right, so we start moving these. This is a periodontally involved tooth. So as you trip it up, you look like this bone going around, but then you leave it and the bone stays with it as it goes. Now we'll look here, now they're that way, and when you're bringing these teeth out, you have this wire go down like this, and that makes the root go with this. It's even better if you bend the little loop like this and drop down and make a circle like this, and then come out here. And you straighten that up and put it in there, and it pulls the roots forward as you pull the crown. You don't have to go in and put something down to get the roots to come forward. This will bring the crown back and the roots back at the same time. Now, we started out and we went rather slow in this periodontal area over here. Now here it is further down the line, and we were doing that bend. This actually a wire was going down like that. That brings the root along with the crown. Now here we've got that going, and you can see these roots are coming along. We got this touching here, this off waves. And then you just keep that pressure on there as you get it together, and it brings the root further forward in here. And this looks like bone loss, but that's the attachment is up here, and this bone fills in around there. Now we rotate this tooth, and it's going to script a little bit, but then we pull it back and torque it, the root in, and the tissue comes back over the top of it. Now this is further on down the line. We've got these teeth now right underneath the upper teeth, and we'll continue bringing this back. Now, at this point, we had not removed. This is a 6-year molars where we're going to take them out. And you want this ready to go when you take that tooth out. And I can close that space in a very relatively short time. But if you let the cortical bone grow over and make a knife edge ridge, it'll take a lot longer to close that space. We're going to move all these teeth back to about here somewhere and move these teeth further up here. All right. Further on down the line, she gained a few pounds, and then she also lost them later. But this is the same lady. She's a stewardess for American Airlines Southwest Airlines while we were doing this. So we were coming back, and we were making space here, and we're going to turn this, and you'll see the gum tissue drop down around that. Now we're moving these teeth back. We're using this elastic thread to pull these teeth back. You could use anything. Now we start this correction immediately. The day you take the teeth out, you have it all rigged up. So we start pulling these in that direction. As I pull these back, open up space here, we turn this tooth around, and we're going to probably stop pulling this back and bring the rest of it from the back teeth forward. And while they're forced to bring these back, we're pulling the upper teeth forward. And the force to bring these, we're pulling the lower anterior back. So we're pulling them back from two different directions. Now here is this large arch wire, and then there's a rectangular wire on the other side where we're putting buccal root torque. So as we expand these teeth, we're bringing the roots out at the same time up here. And that's the way it happens. You look at the tooth here, you see that crown moving more than the roots. You slow down on this force, and this is the big daddy force bringing it out like that. Now, we spread this out, and we used a wire here, and if you get a rectangular wire in there, put torque in it to bring the root out. And instead of the root going out, if you didn't have this big wire on it, the crown would go in. So, but we've got so much force out of this big wire, it's bringing this out, and it's bringing the root out too at the same time. Now, we're closing the space. More of it's gradually going together. We got room here. We turn this tooth around. Then we torque the root back into the bone structure. But you see how this stripped out. And that did because the root is wider down here and it's laying here, and you turn it sideways, there's hardly any way you can keep from losing some of the root structure into the bone, and you lose some of the attachment there. So tell them about that when you start. Now we've got it round. Now watch this tissue will heal up here better. Now we're torquing this back. We're going to put a rectangular wire and it'll bring this root back in the tissue here. Now the space is this much. Remember, this wire goes down like this, and that's bringing these roots forward, and it's pulling these back, and that root will lean out, but this will tend to bring that root forward, backward there. Now we're going on with the case, and it's closed down to just a small, about half the space is left. We do this. Now here is where she gained the weight, I'm sorry, and she didn't like that, so she lost that weight again. And now we've got her just about corrected as we come back. Now, as I was moving the upper teeth out, you have to run interference for these teeth. So we built a lip bumper and put in here, and I've got that videos on how to build a lip bumper and show you. Now look at this tooth. See, it's getting some of this tissues coming back up around it. And so this, if you take teeth back and you're pushing against any kind of force at all, and you're moving the front teeth out, you need to run interference for them. You have to get a soft bed of tissue for bone to move out. And that's where we put a lip bumper, and we kept a space between the lip bumper and the tissue. And so that as we went forward, we advanced this loop back here bigger, pushed this out further, and we kept a space behind these teeth right here. And as we went back with these, we kept them at the same angle. Now, we're just almost together. Here is together, here this needs to be rotated some. Now look at these teeth. They're lined up good, and they're about where we want to go. And so we're pulling these two, and it kind of comes out at the right position up here. Now we're getting closer and closer to being correct. We're bringing these teeth back. We don't lean them back this way. We bring the roots back also. As we bring the roots of these teeth back with the crown, we did it by torquing them in, you see. And I'll show that in your Panorex, in your cephalometric later. And we're running interference for these, and the bone is moving with the teeth. And I'm going to have to hurry on through here. Now we've finished the upper, and we take it off and put a retainer up above to hold the teeth right in that position. Now we've got them in class 1. They're coming down here. And this is a 6-year molar, but this molar underneath here is the second molar of the of the lower arch. We pull the second molar into the 6-year molar spot and then pull the wisdom tooth in the other part. Now this is 91, and we started in 87. I think it was the end of 87. So now she loses the weight, and this is 91, and it was 87 when we started. I don't know what month it was, but this has not taken the 4 years. We did it in about 3 years' time. Now the face is almost normal here. The chin is back here. It was out further. It's back underneath. This is filled out more in this part of the face. Here she smiles now, and you don't see this class 3 problem. And so we show her 20, this is 2nd of 87, and now it is 91. There's about 20 some odd years here in the difference in this case and this case here, right here. But this is the same woman. Now, you look at it from this side, it fits together. This molar was out of here. I don't get the picture on the side good enough, but it is back under. This is that molar. It's here. It's kind of turned in a little bit. Now the one back here is correctly rotated. In other words, this tooth is sitting right at here. You can see it fitting right in underneath that area. This tooth right here, the tissue has come back. We put the torque on it, and we brought the root in right there. Okay, here's looking down on it. You can see this is wider than this is over here. We jumped out of the crossbite and we widened that out. And this is wider here. In other words, we brought both of these areas out, and we brought these up, and we expanded that. We brought some of this back, straightened this space out right here. This is 20 some odd years after we had finished. 87 to 90, 87 to 91. So let's not take that back. It's not 27 yet. We will see her there. 87 to 91 is just about 4 years, something like that. Now here she is later on down the line. Now this is, I think this is 2010. We'll get a date on it here in a minute. And this is held up all this time. I think this is 2010. Look at the class 3 problem. It's completely gone away. You don't see it. But Begonian did not go back. We didn't have to do a genioplasty on it. Now, here, she could do a little better job scaling those teeth back here. But this is this mouth 20, I think this is like 23 years after we did the case. And I'm going to show it here. We got pictures of her. I know where she lives now, and she has a good friend that's a good friend of ours, and she visited her, and I got her pictures just recently. These are the teeth, the way they fit together. And this case has not relapsed one bit, and neither have any of these 7 or 8 other cases that we have done this way. They have not relapsed like that. And this is the way it beats on the other side. we lost a little bit of that over the next 20 some odd years. Now this is the case. This is a second bicuspid. This is a second molar right there. Same thing over on the other side. Now this was the upper arches. They're all three there. The wisdom teeth kind of dropped down. They didn't have anything to hit very good. We left them there. They didn't cause any problem, and so we just left them in there. This is the upper arch. And here is the lower arch. This tooth we didn't rotate it as good as we need to. But this worked out good. And these teeth right here lined up good. She's lost a little bit of it. And I think this is after we had finished. The left side looks good. The right side, good. We need to rotate this jump back in a little over here. Not exactly like I like it. But that's nearly, the relapse is very, very slight. Now, here we brought the lower anterior teeth back, and you see Peconium did not move back. And as we went across these teeth, bringing this back in, it looks like we lost some bone structure, but we carried the tips of these teeth back in this way. And so the angle of these teeth is good, and this angle is good down here. And we have the amount of overjet and overbite. Here this is. Now this was January 7, 2010. So this is like about 3 years, seems like. It'll be 10 and 3. So it'd be 23 years later. She's here. And this is the way these teeth look 23 years after we treated her. Now, we found this lady just recently, and her friend took pictures of her. That's her teeth back in 2010. Now, we'll go and look at it today as we widen this out. See, this is wider. It's out. You can measure across there. You can look at it and see that. Now, this was her pagoda when we started. Here it is after we finished it. And move back. You see the roots of these teeth. We brought them back in. They're fitting in over there. And that's 1987, and this is 2010. I don't have the symptometric, but here's 1987, 2010. It looks like that. Now we're going to take you from 2010 to 2025. There she is, smiling. The teeth have held up 37 years. Here she is. Now this is just a few weeks ago. We got her back, and our Samer took her picture, and she gave it to me. And you can put them up here beside. This is the same woman this is. And you can look at the eyes or anything else. This is held up for 37 years, we're going on 38 years, and it'll be that way when she's retired from there, from the Southwest, and when, if she lives as long as I do, her teeth will stay that way. And this is why I'm promoting this way of treating class, you do double saw shirt, the same results that you get if you go in there and cut it loose. But the expense is nothing compared with what the hospital expense and the expense of doing double saw surgery. And this should be taught to people all over the world. And I am sorry we got one guy in our organization that has done one case on it like it. And he didn't do everything like I wanted to, but he did it and it worked out too. So this can be done on people all over the world, and it would prevent so much of this surgery being done. And if you want to, I don't want to give you her name, but if you could find this lady, she is a stewardess for Southwest, unless she's retired since we did this. And that's what I wanted to show. I'm having a trouble getting this across to people. This is what orthodontics should be doing instead of messing around in these simple, easy things, and people think that your bone won't move after you're older. We do people now in their 50s, 60s, 70s, and 80, and I've had some people go into 90s, and it can be done that way. And I'm going to show you another picture, a video later today, where we did restorative dentistry instead of putting bridges and implants and everything else in there. We just pulled all the teeth forward and corrected. And I will show you that case. I've got several thousand views on this woman. I mean in the thousands. And people have seen it. And this is the way orthodontics will be done in the future. And I know that because people are going to demand this. They write to us all the time, where can I get this done? They go to somebody and they say, well, you're over 25 or 77, you're 27, your teeth won't move. This is a big, what a little boy said, that's an untruth. You can straighten your teeth, you can do all this as long as you're living. So I'm going to go, and I think that's the end of this video. Thank you for watching, and wherever you are in the world, I don't know where you are, but learn how to do this type of case. I mean, you can treat people that need surgery, and I have about 8 cases like this. If you get in our videos and go to Class 3 correction and watch what we do, non-surgical Class 3 correction. And we have treated all these cases, and they're all holding up. They're not relapsing. So I'm going to close out now. Thanks for watching, and I'll close it up.